Welcome to ScheinTV. I'm Peter Norton. As dentists, we're always on the lookout for better, easier, simpler treatments for our patients. I mean, that's good for everyone, because as our treatment offerings improve, we see enhancements in our own professional lives, as well as in our patients' satisfaction and health outcomes. This evening, I'm pleased to welcome back to ScheinTV Professor Laurie Walsh, who has kindly agreed to give us an expert introduction to a piece of powerful new technology. It's the Gemini 810 and 980 diode laser from Ultradent. Laurie, thanks for being with us again.
Thanks very much, Peter. It's great to be here.
As always on ScheinTV, we'd love to hear from you, so please send us your comments and questions throughout the webcast. If you're watching us on Facebook Live, make sure you're watching us from the Henry Schein Facebook page, because we won't see your comments if you submit them from any other Facebook page. By watching us, you're eligible to claim 1 hour of scientific CPD, and we'll let you know at the end of the episode how to obtain your CPD certificate. Laurie, you wear a lot of hats in the Australian dental fraternity, which make you a bit of a go-to guy for things like special needs dentistry, infection control, and emerging technologies. Tonight, I think we're going to mainly ask to speak to tech head Laurie, but if it's okay, from time to time we might ask for some input from your other dental personalities.
That's perfectly fine, Peter.
We're going to see the Gemini laser in action later in the episode, but what would you say to a dentist who hasn't really used a diode laser before and is just sort of starting to wonder about if and when they should include laser treatments in their repertoire?
Yeah, that's a great and important question, Peter. Almost everyone's learnt how to do some soft tissue management at dental school, and most people have probably used an electrosurgery unit in their practice. The way that you actually touch the tissue with a diode laser is actually very similar to how you would use a diode laser. Electrosurgery, diode laser both work by touching tissue in contact mode. But the big difference is there are lots of things you can do with a diode laser that you wouldn't or couldn't do with electrosurgery. So I thought tonight it'd be good to probably talk about what some of those applications are, because they're actually really neat, and I think they offer better enhanced dentistry. In fact, when I was thinking about a topic for tonight, I thought better, easier, simpler treatments. Best, it sort of works.
It does,
as a little bit of a theme.
Want.
Yeah, that's right. When I first started doing oral surgery with a laser 30 years ago now, the things that really struck me about it was precision and control. It was the ability to manipulate soft tissues in a way that's determined by the optics. When you touch tissue with electrosurgery, every time you touch the tissue, the interaction becomes greater. This is why sometimes you run into the alveolar bone crest and you might even get bone sequestration. With a laser, you don't get that effect. The zone of interaction moves as you continually touch the tissue. So the chance of getting some collateral injury is very, very much less, which is a great thing.
Is it still possible to damage the bone with a laser?
It depends on which laser you use. We have some lasers that, for example, will actually cut bone. They do that really, really well. But these are often referred to as the hard tissue lasers. They're not the ones that we're talking about tonight. They're a sort of a different family in the broader sort of church of laser world, if you like. The really neat thing is when you have a laser wound, it heals a lot faster than an electrosurgery wound. It's not painful afterwards normally, and it doesn't scar as much. So there's a couple of advantages for the patient, as well as, of course, for us who are actually doing the surgery, which is sort of pretty important. They look really different. And I sometimes, with my patients, say, this might look a bit like a barbecue and smell a bit like a barbecue. And in a way, it's a sort of a type of a microscopic barbecue. What you're doing is you're heating up the cells to the point where the water inside the cells explodes. And we often, when we look at the surface of a laser wound, for example, we look at this particular case here, we've got a before and after showing this little bit of a gingivoplasty that I've done. This surface has been created by the heat of the laser tip as the tissue has been sort of boiled away on the surface. But that actually creates a type of sealing effect in the same way as if we're cooking a barbecue and we sear the steak on a hot plate. It does pretty much exactly the same sorts of things. And that seared surface acts like a wound dressing, which is one reason why people get less pain. But really cleverly, the same seared surface is what cells migrate over. So it acts like a type of scaffold for a wound dressing, which is a really useful point. Within the family of diode lasers, there's actually quite a few different members. So I thought it might be good to actually talk a little bit about the members in the family. Different numbers, because the Gemini laser's special in that it has 2 laser wavelengths for treatment and another laser wavelength for determining where the beam is actually pointed. And I'll demonstrate that when I do a little hands-on session a little bit later on. So each of the lasers in the family interacts differently with water and pigment and blood, and that means they cut at different speeds. The lasers which have the longer wavelengths absorb a little bit better into water, and that's a really good thing. So water has these absorption curves that basically run all the way down and end. And if we absorb into one of those peaks, then we're going to cut a whole lot faster. And that's a really good thing in terms of the speed of surgery. When we absorb into hemoglobin, which is an important target molecule, over here we've got the hemoglobin, both the hemoglobin from venous blood and the hemoglobin from oxygenated blood. You can see that all the lasers absorb pretty well, which means they can all give pretty much blood-free surgery. But the speed of cutting varies. The 810 is a slower cutter, the 940 and the 980 is a faster cutting laser. And hence the idea comes up, well, what about blending them together to try to get some of those different advantages? And this is one reason why it's really clever to have a wavelength multiplying type of laser where you can actually choose one or the other, or actually to have a little bit of a blend. It was the first laser in the world to sort of come up with that concept, which I think is a really good thing.
And correct me if I'm wrong, most other soft tissue lasers in dentistry tend to have just the one wavelength, is that right?
That's the normal thing. So for the first 28 years of laser dentistry, we would just select a specific type of wavelength from a box or a pen, and we would then use that on the patient. That's probably why I end up with 24 lasers in my collection, because I had to have lots of different wavelengths for the sort of things that I actually do.
That doesn't sound like you at all, Laurie.
No. I guess the interesting thing is when you have 2 different lasers in a box, how do you actually control the effect? And you'll see tonight as we put some of the settings in, we're going to control the power of the laser, but we also control the speed that we move the tip across the surface, and obviously the time that we're on the surface. And these things are very similar to electrosurgery. When you go slower, it's going to cut deeper, for example. So the learning curve is actually not difficult. If you take someone who's already a good dentist, it's not hard to turn them into someone who can use a laser and be a good dentist, as long as they understand that the interaction is driven by the optics and not by the flow of electrical current, which is what happens with electrosurgery. But both units produce smoke, of course. And electrosurgery you can't use around dental implants that are made out of metal. You shouldn't use it around amalgams because of localized heating, but you can use a laser around those things. And so it's a bit more versatile than electrosurgery. There's been a lot of changes in the diode laser field in recent years. For example, we have a code in the ADA schedule, 945 is the item code, which actually covers the non-surgical things you can do with a laser, which could, for example, include disinfection of a root canal or a periodontal pocket, or treating an ulcer to seal the surface, or blocking pain, or doing pain therapy. These are things that we didn't really have codes for, but you can do with a laser. So having that code, I think, is a really good thing. Released in March last year is the new Australia-New Zealand Standard 4173 on laser safety, which covers all the different states of Australia and basically explains the principles of how you set up a laser to work safely. And now we've got the emergence of these different sort of multiple wavelength diode lasers, which then give you the versatility of applications of different sorts of laser wavelengths. It's a bit like, trying to combine many things in one all-purpose type of box, which I think is great, because it's just one thing to carry around instead of having 5 things on a bench. So I think that suits the style of modern dentistry today really, really well.
Absolutely. Well, thanks for watching, and thanks for your questions. We'll get to as many questions as we can. If you're watching us on Facebook, we'd love for you to like and share the video. So back to you, Laurie.
So tonight we'll talk about a few different sorts of surgery, from surgery for frena and tongue ties all the way through to gingivectomies, gingivoplasties and troughing and things like that. The very first couple of patients I treated 30 years ago were patients having gingivoplasty. And we soon discovered that this was a really great way of being able to get better impressions and better management of someone who is having some sort of crown and bridge work. Because with the diode laser, we can basically run around the patient's tissues, and we can do this as well as using, for example, cord or exposil, or in fact, instead of using cord or exposil. because we can dry the tissue up, but we can also slightly extend the contours of the crevice, which means you may not need to use cord. If the tissue is very inflamed and bleeding, you can obviously stop the bleeding by using the laser as a coagulating tool. So that's actually really versatile. And I think in the patients I was first treating 30 years ago, there was a whole bunch that we began to explore how to optimize this specific application.
We have had some questions on that front. When it's being used for troughing around a crown prep, do you have any concerns about gingival recession?
So when we treat tissue with the laser, the interaction with the diode laser is normally in the order of about 1/3 of a millimeter or slightly less. So if there's going to be a change in the tissue, it's going to be somewhere less than that dimension of precision. If we're using trichloroacetic acid or electrosurgery or ceramic burrs or something else on the tissue, the zone of interaction is going to be bigger. So it's the most precise tool that we have, and in fact you get less recession after using a diode laser. That precision is actually a really important characteristic of using a diode laser. Very, very much so. Yeah. So if you've got a case like this, for example, where you want to go around these couple of crown preparations, we can basically just skirt around those with the tip of the diode laser, and we can control bleeding, we can reduce fluid, and in fact we can then go on and take an impression at the same time. So that can be very useful if you're doing particularly multiple units at one time, which is often how people would work.
The tissue discoloration we can see on that image, how long would we tell the patient to expect that to persist?
I always tell the patient it's going to look brown with tiny black dots for about 3 or 4 days. Oral mucosa will normally begin to migrate over that at roughly 1 to 2 millimeters a day. So if it's a very small thing like a gingival crevice, that will basically turn pink in a couple of days. And I'll tell the patient, once it's turned pink, wait 1 day and then you can begin to brush it gently, because you've now got a covering of epithelium or mucosa back on the surface. But initially we want patients to actually leave that brown layer there, because that's actually the wound dressing or the bandage. It looks a bit ugly. It tastes a bit like burnt steak, by the way. If you're wondering if you can taste it, the answer is yes, but patients don't seem to mind that. But it's not painful. That's the good thing. It just looks a little bit funny.
I think patients will love that. What can you tell us then about, I mean, that's obviously for troughing, for example, but for soft tissue crown lengthening, presumably the lasers are quite good for that as well.
Very good. So if you need to, for example, take a little bit of tissue away because you've got some root surface caries, for example, look at this case here. We've got a lesion right on the cervical margin and it's sort of going submarine. Well, I don't like doing submarine dentistry. You know, I don't think any of us were born with periscopes on our head. So what we can do with the diode laser is just scallop away some of that tissue, and now we've got dry margins. We can see them, we can instrument them, we can etch them, and we can bond them. We just need to just gently stroke the tissue with the tip, ever so lightly. It doesn't take a lot of time or force to do that. And I think that can turn us away from being submarine dentists. We don't have to worry about boggy, inflamed subgingival margins, because now we can actually do something to that tissue, which I think is really important.
Should we ever be concerned about air emphysema or surgical emphysema in a situation where we've just done some kind of minor surgery and then perhaps we're washing and drying a tooth?
Yeah, an interesting question. With a diode laser, you're not using a water spray, so you're not introducing new things to the tissue. So you're not going to get an emphysema type of response. You could get that if you used a triplex and were very heavy-handed, but you would normally be irrigating with something which would be something like sterile saline, for example. So you're not going to be using a lot of force with that. So I've never seen it, and it's not been reported in the literature either. But that's an interesting question, and it comes up all the time. Thought I just might show you an interesting case that we did recently, which is the daughter of a patient who I treated about 20 years earlier. And mum and daughter often look very much the same, and that's the case here. So they both have a syndrome which has a number of unusual characteristics, but the dental one is to have this type of gingival fibromatosis associated with it. So there's a lot of excess soft tissue which is present. So what we basically did, you can see on the upper image, we've just basically sort of put in the periodontal probe to measure the amount of tissue which is there. You can see that up the top over here. Then we've just used the laser to do a little incision to select the tissue. And this is a really important point with a diode laser. You don't have to sit there and erase tissue by stroking it like you saw in the previous case of the cervical lesion. You can actually just use it, in this case, just like a scalpel, and cut the physical piece of tissue away. And here's the neat little bit of the story. The laser tips, if they're initiated on the side, will actually cut on the side as well, which means we can do a bit of beveling, which is what I've done in this case here, just to give the overall contours the right thing. And this was a simple procedure. In fact, I was training a pediatric dentist in how to use the laser, and this was a case that we did as a teaching case, but this was like less than 5 minutes later. So a very, very simple thing to do with very, very small amounts of injected local anesthetic.
And how long would those tissues take to resemble more normal looking tissues in that case?
So like in a case like this, we would tell the patient it's going to look a little bit brown for about 2 or 3 days. By the 4th day, it will start to be pink, and on the 5th day, you'll be able to start brushing it.
So is that essentially the same instructions or the same warnings you would give a patient for pretty much any time you've used the laser?
Almost exactly the same. There's very, very few times we would ever vary that advice. It's almost like a standard sort of advice that I would have used over 30 years. Similar in a case like here where we've got a 2-4 that we've turned into a 2-3 by just doing a little bit of soft tissue crown lengthening just to improve the aesthetics. It's a very, very small little procedure. We'll tell the patient just avoid brushing this area for a couple of days, and once it goes pink, wait 1 day and then you can start brushing it. One thing when you're using a diode laser, if you choose settings that are too low and you spend too long there, then the coagulation part of the diode laser, which is what seals the surface, you can actually extend that effect into the tissue. Recently there's been some interesting work done about the idea of intentionally destroying tooth germs, particularly of third molars. Now this of course would be the end of a wealth creation plan based on removing third molars, but if you actually go in and use the coagulating power of the laser to destroy the tooth germs, obviously then they won't form a tooth. I guess my point is that lasers can coagulate tissue if you stay there for a long time. And the case you're looking at here, this was a case treated by a couple of my final year students. It was an operculum case, and what we've got here is the removal of some of the tissue around the molar tooth, but it's actually taken these students, because they're novices, a lot longer, and as a result they've actually got a little bit more collateral injury. That's why the tissue looks a little bit white and a bit dry. So that would be a sign that someone's been puddling around there a little bit longer than they might have otherwise done. It doesn't look quite so well done, which is what you saw on the earlier images there.
So it should be in there and
get in and get out. Yeah, I always use the principle as much as necessary, as little as possible. Get in and get out, and that's why it's good to be able to alter the settings. On the Gemini laser, for example, the mode the laser begins in gives us a menu with different settings. However, we can actually override that and manually drive the settings by just literally dialing them up, and that can be quite a useful approach too.
Do we have any concerns about a lingual nerve damage in a case like that?
You always need to think about where the lingual nerve is, absolutely, and you would always be using, I normally use something like a flat plastic as I'm going with the laser to make sure there is absolutely no way that the laser or energy from the laser could actually extend on the lingual surface. Absolutely, that's a very good technical point, always. In a case like this, we've got a very superficially placed canine tooth that we're just going to do a little tiny exposure on, using a bit of local anaesthetic and just cutting that away. Now the neat thing is, because diode laser wounds are non-bleeding, they're non-oozing, so we can actually etch that tooth at the same appointment and stick on a bracket. We don't need to wait for it to heal.
It's fantastic.
Which is really good. A lot of orthodontists find diode lasers really useful for that purpose, and many orthodontists who I've trained to do that like it. Similar things for exposing an implant, for example, in pediatric dentistry, doing a pulpotomy to seal tissue off. So I'd call those things doing the dentistry we normally do, but perhaps faster or better. But then that sort of leads on to, well, what about things that you couldn't have done normally? And I think the first one of those I'd like to talk about is wound trading. So as the name suggests, you give me something and then you get something back, which is different. So if you have, for example, an aphthous ulcer, an aphthous ulcer will hurt, they'll often become secondarily infected and painful. Using the diode laser with a non-initiated tip, we can basically paint the surface and create that coagulated zone of tissue. That laser wound will heal at that 1 to 2 millimeters a day without pain. So the patient has gone from having a break in their mucosa to having mucosa which is sealed. They've gone from having a site which is infected to one where the organisms on the surface have been killed by the photothermal effect of the laser. And they've gone from a situation of pain to a situation of being out of pain. So they've actually traded a laser burn, effectively, very superficial, they've traded that for a painful ulcer. This has been used for mucositis, for chemotherapy ulcers, and even for hepatic ulcers, but it's most widely used for aphthous ulcers. And it's one reason why I thought it'd be useful to have an item code for it, because it's a small but very valuable service to a patient, because many patients get apathy, so it's a nice thing to be able to do for them. And so that's literally swapping one thing for another, which is an interesting concept in dentistry, really.
And is that suitable for major apathy as well as the minor type?
It can be, but you always have to investigate a patient with major apathy, particularly hematologically, to see what underlying problems they are and to make sure they don't have contributing factors, or they don't have sometimes a vesicular bullous disease, which is, you might have misdiagnosed the major aphthous. It may actually be a bullous lesion in the first place. Yeah. Here's another example of something which is completely novel. It's an implant that's been placed in an unusual place, way too far to the buccal, and out near the external oblique ridge, and there's been a lot of proliferated tissue around it. However, the interesting thing is that when we treat that with a laser, by altering the tissue temperature, we can actually also alter the keratin pattern. And this is sometimes called neokeratinization. We've used this a lot in our oncology patients who've had implants where the tissue around the implants has been a skin graft rather than oral mucosa, and it often proliferates badly. So we've been able to, rather than graft those, use this laser treatment to actually create a keratinized bed that patients can clean against very, very well, rather than more delicate sort of mucosa. A new procedure that really came about because of lasers, I guess. Here's a case where a patient's got a mucocele in their lip, and we've used the laser to basically scallop out around the mucocele and destroy the little salivary gland at the base. Now, treating mucoceles is not a big part of someone's practice, but most of us would probably avoid doing surgery on lips or tongues because they're sort of nasty things to work with. They bleed a lot, it's sometimes hard to see. But when you've got control of bleeding, it's a lot easier to manage the site, and so you tend to be able to do things like this that you might have avoided before. Here's a little slide showing you a patient who's got the aphthous ulcer, and this is just to reinforce the point that here's where that 945 code could actually be very applicable, because it talks about non-surgical applications of a laser, and here we're not cutting the ulcer out, we're actually just painting away the surface to alter the nature of what that surface actually is. Think about it like if someone has laser resurfacing of their skin. You remove some of their skin and it regenerates, but you seal the surface as part of the laser resurfacing. This is the same procedure, but it's been applied onto the surface of an ulcer inside the mouth.
So what is it that lasers can help us with on the periodontal front?
Yeah, so there's been a lot of work done on this over the last 35 years, in fact, and it's all starting to sort of merge into a couple of concepts, and one of them is called laser-assisted or augmented periodontal therapy. It's trying to draw together some of the disinfection aspects of the laser. So lasers can kill bacteria by photothermal disinfection, particularly organisms that have large amounts of melanin. And of course, many of the periodontopathic organisms generate all sorts of different melanin compounds, and porphyrins are a major part of their iron metabolism. So all of the key periodontal pathogens all are very, very rich in melanin. So they're actually readily disinfected by a laser treatment, which is a pretty neat thing. But we can also use the heat of the laser to help release growth factors from platelets, and we can use the biostimulating effects of the laser to accelerate wound healing. So if you sort of combine those three things together into a blend, you end up with a concept often was earlier called laser curettage, which was probably not a good name. It was a bit simplistic. But now I think the idea of treating the site with the laser after doing debridement does those three things. Kills residual bacteria, helps release growth factors from platelets, and it boosts the healing potential in the site. So three little parts that could perhaps give improved periodontal outcomes. And there have been a number of studies done on that. Here's a patient who has a periodontal lesion, happens to be an angiogranuloma. We've gone there with the laser to basically excise that, but also to treat the area so that the inflammatory condition which led to this isn't going to recur. So once again, we're trying to use the three same features, but now to modulate the effect of what we're actually getting. The idea of photothermal disinfection is actually linked to the way that sometimes lasers can enhance bleaching. It's by controlling the amount of heat, which then drives a few other reactions. So it sort of sits on this bucket of what I'd call some of the emerging or cutting edge types of applications of the diode laser. And then we get to the things which are, I guess, are some of the special things that really only lasers can do very well. And the first one of those would be laser activated irrigation. What we are doing here is using the 980 nanometer wavelength, which absorbs in water, to actually warm the water up, which changes its absorption, and then the water begins to become physically agitated. And of course, what's in the water is sodium hypochlorite, EDTA, so water is the base of the irrigants that we use, and these work a lot better at elevated temperatures. We first published this about 12 years ago in the Journal of Endodontics, and since then we've done many studies of the nuances of this effect. But it's incredibly good for killing organisms and for removing smear layer.
This water agitation, are we talking actually boiling the water, or is it's a different kind of agitation?
So at the very tip of the laser, the water actually does boil, but only for a number of microseconds. What happens is these little bubbles of steam are created, but because of the pressure of the surrounding water, those actually then implode. And what we effectively have is a type of cavitation event. So we have an explosion followed by an implosion. When the implosion occurs, we get the movement of fluid in a special way called jet fluids. And this basically creates a very fast moving scouring effect, which is why it removes lots of biofilm and also smear layer very, very well. We first showed that with hard tissue lasers, and then we went on to show it with diode lasers subsequently. And that's then led to the idea that you can augment endodontics with better disinfection by using this sort of fluid agitation protocol.
We have had some questions about diode lasers for endodontics, the most recent one being, would you recommend using a laser as a final process in reducing bacterial load? Is there any clear evidence that it's better versus just using irrigants alone?
Yes, there have been many studies, and there have been quite a few systematic reviews for several of the laser journals that I review or edit. Certainly a number of those systematic reviews in the last year I've seen as a reviewer or editor. So we've now got actually very large bodies of evidence around most of these questions. We've done some really neat work on photodynamic disinfection and also on photothermal disinfection. Whenever you're using some sort of controlled heat, a really important question is, could that heat actually warm the whole root up and maybe damage the periodontal ligament? So we've done some really neat studies with infrared cameras and with thermochromic dyes and miniature thermocouples, all these different methods to measure heat. And we've shown that done correctly, you don't heat the outside of the root or the periodontal ligament by more than about 0.5 degree, which is basically biologically meaningless. So you can actually do a terminal disinfection with the laser after having done all of the traditional root canal therapy without actually creating additional problems of heat. But the light does go further than just the root canal. You know, the diode laser wavelengths will go through the dentine. They will stimulate healing in the adjacent tissue, which is really good.
We have a demonstration coming up shortly,
Yes.
not specifically on endodontics, but it is a demonstration. But just back to endodontics, a question, how long do you use the laser for endo? Presumably, how long would you apply the laser per canal?
Yeah, so the laser would always be used in a pulsed mode. The laser we're showing tonight is a super pulse laser, so it runs at 50 pulses per second. And you would normally treat a canal at between 1/4 and 1/2 a watt, and you'd normally do that for about 1 minute per canal. If you wanted to treat for longer because, for example, you were worried about connections between canals, for example, the mesial root of a lower first molar, where you have lots of little intricate connections, then if you're going to treat one canal for longer, you would replace the fluid. We've shown that that improves the effect. It does that by lowering the temperature as well as physically flushing some of the material that you've basically broken free because of the laser-associated irrigation effect.
And is that with an initiated tip or an uninitiated
Now,
tip?
you use a non-initiated tip for that. You get the best type of formation of those little explosion events right on the very end of the tip if you use a plain uninitiated tip.
All right, thank you for your questions. We're getting through as many as we can.
Excellent questions, thank you. I wanted to talk just for a few seconds about controlled heat for bleaching. The breakdown of hydrogen peroxide, of course, is very much dependent on temperature. That's why we keep peroxide solutions in the dark and also in the fridge. And if we warm them up, the chemistry of breakdown can be accelerated. So there's been a bit of work done on just using the diode laser as a controlled heat source to warm up a bleaching gel on the surface of a tooth. And that literature shows that it improves the action of the bleaching, but it can also reduce some of the discomfort associated with bleaching because of the analgesic effects of the laser. And the analgesic effects are actually a really neat story in themselves. If you fire laser light into a tooth, the near-infrared wavelengths which we use in diode lasers, they penetrate really well through a tooth, so they will reach the pulp. And many studies have been done looking at how diode laser energy can selectively block nerve transmission. It will block nociceptor transmission very, very well. And of course, in a pulp, the thing we're worried about is pain receptors, so nociceptors. So we're not taking away all the sensation of the pulp and making the tissue become tingly or numb. We're actually selectively depressing the firing of those neurons, which is what all the neurophysiological studies show. This is from a study we did recently just showing how much energy actually goes into the tooth using a series of different infrared cameras. And we found that energy definitely goes into the tooth and can definitely create analgesic effects. But of course, you've got a problem if you've got, for example, a metallic crown, like a gold crown on a tooth, because the diode laser energy can't go through that metal. So you need a window of tooth structure, or you have to apply the energy through the gingiva and then through the bone in order to reach the tooth. And we know it can certainly penetrate 10 or 12 millimeters, so you can reach a tooth by firing it in through the side. Yeah, which is quite interesting. This was an interesting study we did looking in collaboration with our colleagues at Griffith University, looking at the analgesic effect. We just took healthy, normal people, dental students in this case, and looked at their response to electric pulp testing to see how we could shift that response. So you'd need a much higher EPT amplitude and frequency to get a measurable response. So it's quite a neat way of being able to see if you're developing an analgesic effect. But what was really cool about the study was, as one of the lead investigators, one of my roles was to cobble some of the laser equipment. So it made all the right beeps and clicks and sounds, but wasn't actually producing any laser light. And this, of course, is because of the placebo effect. So if I tell you I've got this gadget, I'm going to wave it over you, and I hope it will remove your pain, please God, I hope that it does. Everything is better. So what's really neat in this one is that there in fact wasn't a change at all in the placebo. The variation in the placebo group was less than about 2%, but there was a significant depression when we applied the laser either through the soft tissue or directly onto the tooth, which was really, really neat. And I think that again starts to show the potential of what has been known in veterinary medicine and physiotherapy for a long time. You can use lasers to actually alter pain thresholds in animals and in people, of course. It does actually work, as opposed to using it to kill bugs and alter healing, which is, of course, the sort of things that we've been doing in dentistry for a long time. So the story with pain is a relatively new story, I think, and it's an emerging story with some really great literature now starting to appear on the concept of blocking pain. We've certainly treated some patients with some chronic pain conditions and had really some very stunning results by doing it. And it's now something that many people are starting to get into in oral medicine. People who work in orofacial pain generally are starting to get into using diode lasers because it's non-pharmacological. And that means you've got better control and you've got around the safety features that, the safety concerns rather, that come with a lot of the more potent analgesics, and particularly with opiate medicines, which are a great concern in Australia at the moment. So there's a number of reasons why it's actually good. We've even experimented with patients who use their own diode lasers at home and treat themselves. Obviously, the equipment is different from the equipment we use in a dental surgery. It's much less sophisticated, and has a whole series of controls on the exposure, but that also works really well.
We've had plenty of questions about treating periodontal conditions. So,
Yeah.
I mean, what sort of protocol do you use when you're using a diode laser in a perio setting?
So if you're using a diode laser, you always have to do your debridement first with ultrasonic instrumentation, hand instrument, whatever your normal protocol would be. And then, having been around the site, you know what the probing depth ranges are in that site. You need to insert the tip of the laser, uninitiated, to that depth, and you need to lase as you withdraw. So you're using an action like a periodontal probe, where you're walking it around the tooth, but your foot is only on the go pedal as you're actually on the upstroke. And that's done in order to actually spread the light around. If you look at the slide on the screen here, the top images show the irradiation zone that we mapped out way back in 1993 when you lase on withdrawal. And you actually end up exposing the root surface where you may have some residual biofilm, you have some activation of the pulp, you have some activation of the coronal bone, the marginal gingival tissue. So it's used in a pulse mode, either between a quarter to half a watt, but it's on withdrawal. You don't laser as you go in, because obviously if you did that and you simply kept pushing, you'd end up actually ablating or cutting tissue. So to make it safe, and this type of disinfection's been done in many periodontal practices, including by dental hygienists, for example, if you do it on withdrawal, it can never turn into an accidental surgical procedure. So that's just a design feature that makes it nice and safe to do. Yeah. There have been quite a few studies done on it, which have tried to pull apart those different mechanisms, the antimicrobial effects, the release of growth factor effects, the boosted healing. And we could talk for quite a long time around that. But the key point is that the diode laser itself is not a debriding tool. It's not going to remove your calculus. So you need to do that. You need to remove the biofilm and calculus. And then at the very end, it's then the time to do this post-procedural disinfection biostimulation step. It's an augmentation of traditional treatment at the very end. And I guess the emerging evidence shows that it does add value to that. This study, which was done by our collaborators in Austria, showed that there was fewer bleeding sites, better post-surgical results. And they did a follow-up study where they looked at what was happening microbiologically. And this is actually really neat. They looked at the total counts, which is TC on the slide here. They looked at aggregated actinomycetium comitans, Prevotella intermedia, and Porphyromonas gingivalis. What they found was that the bacterial reduction results were not only better with the laser, they were also more consistent. So you left fewer organisms behind, but actually you achieved that consistently. And I think that's one of the advantages of that type of protocol, is that you're not really sure what you're leaving at the end, and this is a way of basically making sure that nothing is left behind at the end, which is probably why it's been a very successful thing in periodontal therapy and in dental hygiene, particularly in North America. It's not quite so commonly done in Australia, but a number of practices are certainly doing it now. Yeah. The similar sort of thing in endodontics, what works around a tooth can obviously work inside a tooth, or indeed even around a dental implant. But the optics are somewhat more complex, and the shape is a little bit more complex endodontically. We talked a bit about how the activation of fluid works with this increased temperature where the irrigants are basically warmed up, but they're also physically moving. We've studied this with high-speed photography and shown that these little bubbles form that explode and implode, as we talked about. But it's almost like the dam busters. If you remember seeing the famous Dam Buster movie, where they sort of drop the bombs, it looks like nothing happens for a while, and suddenly everything busts. It's exactly the same thing. When you put a diode laser into water and you run at 980, initially nothing happens that you can see with your eye. You can with a microscope. But then suddenly you start to see the pulses created and the fluid agitated. And that's because the water around the tip has to warm up. And once it's warmed up, that alters its absorption, and then you start to get these little events. So it has this little delay for a couple of seconds, and that's one reason when some of our collaborators overseas have used diode lasers in water-based fluids, they've told me, it doesn't agitate them. I said, best because you didn't wait long enough. If you look at our published research in the Journal of Endodontics, it actually takes a few seconds to start up, and then it gets going.
Well, we're getting to as many of the questions as we can. I'm sorry in the time available. You have some photos of teeth that show the complex canal anatomy that really sort of hammers home how important activation is of irrigants.
Yeah. So on the slide here, you can just see some of the different things that we found in canals. And of course, we know with regular instrumentation, you only touch roughly a third to a half of the walls of canals, particularly in complex oval-shaped canals and fins and deltas and isthmuses and things like that. What we found is when you put the diode laser tip in and you start to agitate the fluid, what you're seeing here are a few frames we've selected from some high-speed photography that we did in teeth that were clear, so you could see into the action here. You can see these formations of these little micro bubbles and these macro bubbles that then collapse to give you these little tiny micro bubbles. When we then looked into the teeth, we looked at the apical 2 millimeters of the tooth. This is the place that's the most difficult to clean, the area shown in the yellow box here. And what we did was we deliberately made really thick smear layers by using the files without EDTA or sodium hypochlorite. So just basically smeared everything around, which is what you can see here. We found that when we did conventional instrumentation and then use EDTA, we had these large chunks of smear layer left behind, which you can see here sitting on top of the dentinal tubule. So you can see some of these large chunks just sort of sitting around here, these large blocks of tissue sitting up on the top. What we found was really quite surprising. This is looking at the apical third. You can't see any of that material at all. All you can see is just the normal three-dimensional structure of the apical third with all those little tiny canals. And in fact, there's even the beginning of a small series of little micro canaliculi sitting over here. So it cleans it extremely well. And we tested in one study using a 940 diode laser and showed that was much more effective for smear layer removal when we measured it in a blinded study using this laser activated protocol. So this is one of many studies that actually show there's actually some pretty good evidence around this beginning to emerge now. So I think it's a really, really promising area for investigation.
Speaking of evidence, you have some evidence about how essentially the thermal safety of lasers in this application as well.
That's right. So we've done a number of studies where we've used different types of sophisticated measurement techniques of very, very small temperature change down to about 0.1 degrees using special dyes that change color when they're on the surface of a root, which we can basically spray paint onto a root. And then when we use the laser, we can track how much these show us the little temperature variations in a tooth. And by doing that, we've shown that when you're lasering inside a tooth, that heat is actually contained inside the fluid. It's not actually dissipating out. And it's something that we've talked about and published about for the last 30 years because there's no point having an application if it's not safe to do in a patient. So we've always been looking at thermal safety of whatever the laser technique actually is. This is one of those thermal stress studies. So if you can see some of those really subtle changes here, what you're looking at here is a series of what looks like rainbow colors. And these are the different temperature gradients created by the diode laser. So as it's used inside the tooth, you get these really subtle little variations in color from these thermochromic dyes that tell you that that's a temperature change of about 1/4 of a degree, which is really, really small. And we've measured them using a couple of other methods as well. But the point is that it's not heating the root above the ambient temperature in any way that we would actually be concerned about at all, which is really, really good.
If it's thermally safe, do we have any concerns about perhaps forcing materials past the apex?
Yeah, that's an excellent question, Peter. And we developed in about 2007 a model of how to do that. And I thought I'd just show you a little cartoon on the screen to show you that. This is basically a nanodroplet assay. So if we're agitating fluids in the canal, the concern is, wouldn't that push some fluid out through the apical foramen? So we worked out a way to measure nanodroplets of fluid coming out of the apical foramen and to digitize those and record them, which is basically shown on a little tiny cartoon here. We did that to then compare what happens if you use a conventional irrigating needle or use a side venter needle like a maxi probe. And we showed that if you're using the laser to agitate the fluid, the amount of extruded material is in the same order of magnitude as if you're using a conventional irrigation method. So it's not actually any greatly more. We actually think in a practical clinical situation, because you're not driving the fluid down with the tip of the laser, it's actually going to be a whole lot less, which we think is a really good thing. But when you just test it from a pure fluidics consideration, it's almost exactly the same. Yeah. I wanted to just touch for a few seconds before we move to our demonstration, just to talk a little bit about this biostimulation concept. It's been around in literature for over 45 years, and there have been over 4,000 papers published on it. A review paper of ours in the Australian Dental Journal has had over about 700 cites, so it's a really popular topic. And I thought I'd just talk a little bit about how this works. The machinery of which we create and modulate energy inside a cell, in mitochondria, is all about electron transport. And at dental school, people might have been partly asleep during that wonderful lecture on the electron transport chain in mitochondria in biochemistry. But that process of passing electrons around between different donors and acceptors is actually accelerated by two different forms of light. One is visible red light, and one is near infrared light up to about 940 nanometers. And diode lasers can, because they can produce those couple of wavelengths, can actually accelerate what a cell does. The cell does what it does, but it does it faster and better. And when we began researching this about 25 years ago, we looked at things like cells that migrate, they migrate faster. Wounds that heal, they heal faster. Whatever the effect is, it's almost like a turbocharging button that stays on for about 2 days. And so we tested out what happens if you keep boosting after every 2 days. You can sort of maintain this state of excitation, which is actually, it's like an electronic type of excitation. It's been extensively used by our colleagues in physiotherapy and in veterinary medicine for many, many, many years. But in dentistry now, we're starting to understand that there's lots of places where we could apply this to wounds that are complex and perhaps maybe slow healing. And that might be the case, for example, and a lot of work's been done on looking at implant integration, for example, or looking at orthodontic tooth movement, where we are moving things through bone and we're trying to speed up the turnover of bone in both situations in a good way. And now we're at the point where we now have quite a few systematic reviews of many studies. So we're sort of reaching the top of that evidence pyramid, which I think is a really good place to be, because it means we've got some really decent laser applications to actually talk about. Yeah, we might talk about those and do some questions after the demonstration, perhaps.
That sounds great.
Yep.
We'll be back shortly with the demonstration, so we'll see you soon. Welcome back. It's now time for the demonstration of the Gemini laser. For this, Prof Walsh is joined by Dr. Aidan Doherty.
G'day, Aidan. Thanks so much for coming along. Good to have you with us today. You're going to be driving the laser a little bit for us. So I thought, as a young laser user, be interesting for you just to tell us for a minute or two while I'm setting it up the major ways that you would be using the laser in your practice at the moment.
Well, at the moment, basically, I've been using it for about 6 to 12 months, and I've limited it basically to using it for maybe some gingival troughing in those patients where you find that there's hemorrhage or you're finding it difficult to achieve hemostasis, maybe in replacement of using cords, for example, like you were discussing before. So I found it really helpful in those really difficult situations where you know the tissues are really inflamed and engorged. Also for gingivectomy and tidying up the gingival margins when you're doing an aesthetic case, for example.
That sounds like you've left the land of submarine dentistry behind, which is really important. That's great. Good. So I've just been putting a tip on the laser. These tips are single patient use disposable items, and they come in two forms, either initiated or not. The initiation alters the temperature of the tip, which makes it a whole lot better for cutting. So I've just popped an initiated tip on, which I'm going to give to you. We'll get you to pop your safety glasses on. I'm going to pop on, my safety glasses are a little bit more spiffy than yours, but so these are those laser loops, basically just laser filters built into loops over here. So we might get you to select a pretty typical gingivectomy setting for us.
Wavelength, standby. General dentistry. Gingivectomy, active.
So you notice that the laser is talking back to us, which is just really reflecting the settings that we're going to be able to do. We're going to use some blocks of salami because it contains the major absorbers of water, pigment and blood that we obviously have in the mouth. So maybe if we just start off by doing, you're going to do a dual wavelength.
Yeah, we'll start with the dual, yeah.
So we'll start off with a dual wavelength, and we'll get you just to make a sort of a long, thin, slow incision on the salami for us.
Sure.
And you'll see a small amount of smoke just coming up from the surface. Not too much.
Smells great, Laurie.
Yep. Smoking salami is a wonderful thing. And we can see the energy spreading into the tissue. Just run over that same area now, just to re-incise the same area for us. It's a great shame that you can't all smell this, because burnt salami is a wonderful thing. And there's actually a slight buzzing sound when the laser is running, because this laser is pulsing 50 times a second. So what's happening is every time there is a pulse, there's going to be a burst of cutting, followed by a little bit of cooling. And you probably noticed that sort of sizzling sound yourself. So let's just switch back to the 810 wavelength.
810.
That's right.
Stand by.
And now just make the same sort of track just coming down along the side. Now the 810 wavelength is a wavelength that we would normally use for these biostimulation, non-cutting or periodontal disinfection type applications. And you can notice straight away that the speed and amount of cutting is actually a lot less. So there is a speed difference between those two things. And I'm sure in your practice you worked out pretty quickly, if you're going to be cutting gingival tissue, you're going to go for the double.
Yeah, definitely. So I'd usually keep it on the dual wavelength for that.
That's right. So what's really neat is because the two lasers have actually been synchronized, those two peaks line up. So that gives a peak power of about 20 watts. But it actually goes like a triangle up and down as it oscillates, which is really useful. Okay, let's now go to the 980.
980.
So
Stand by.
single wavelength.
Active.
There we go. And we'll do exactly the same thing. So what's really nice now is we now have something which is in the middle. So we've sort of gone very fast and very slow. Now we have something in the middle. And that's great, first of all, when people are learning, but also when you want to take off a little bit of tissue, you don't want to cause collateral damage. So that's when the slower cutting, for example, becomes very, very important. And that's actually really, really nice to modulate. Now, while the laser has a whole bunch of built-in settings, being a bit of an old guard guy, notorious for not doing that. So if you just hit the procedures button and turn that off, we can now actually just directly dial up the power by just touching the up or the sideways button. And I actually like this concept of just literally dialing up the power on the screen. It's a really quick way of getting to the maximum power of the laser, and actually saves a couple of button presses as well, which I think is really neat.
So how often would you use this versus using the dual or the single?
So it comes back to the sort of procedure. So if I'm doing something like a pulpotomy, for example, or doing a pulp cupping procedure, I want something which is going to stop bleeding, but it's going to be a very, very short exposure. So that's where I'm going to set the laser up and just come in and just do 1 or 2 seconds of exposure and then bug out.
Yeah.
But if I'm trying to remove something like, for example, a fibroma, or like the gingivectomy case, then I'm going to want to go dual wavelength to try to get the faster cutting. So it's a question of, are you looking to cut fast, or is controlling bleeding really your take home? So you control that from the settings, but also by changing from the initiated tip to the non-initiated tip. So that's a really nice sort of axis of control. Turn the little aiming beam, the little torch on in the tip.
Low.
Yeah. So we have basically a little torch sort of built into the end over here with a couple of little white LEDs. And I found that really useful for doing tuberosity reductions and operculectomies, where you're basically tucked around down the back and things can get a little bit dark, or you're working around a corner. So basically having a built-in torch, I've often found that really, really useful when I'm working down the back. Have you ever used it very much?
I couldn't agree more, especially when you're doing, say, for me, some troughing around a molar, and I haven't got much light and it's difficult, the tip on a high illumination is really handy. Yeah,
it's a really useful thing. Yeah. One of the interesting things with this laser is the tips out of the box actually come straight, but then you can bend them. There is a tip bending tool, and people can also bend them by hand, but there is actually a wonderful little bending tool where we can place the tip in and then basically just slide it back to bend it to the right angle like that, so it just reduces the risk of breaking it. And that makes the instrument much more like a contra angle. So it sort of feels, I find it feels more natural to me when I'm holding it. Yep.
Yeah, I'd agree.
Yeah, that's good. One of the interesting things I've found with this laser is I'll often use it when it's unplugged. So it's just running on batteries. I found by testing it out that it takes roughly an hour to fully charge from completely flat, but it will actually run for about an hour and a half when I'm using it on patients.
Great time out of it, I think.
Which is great. So I just pick it up and just move it from room to room. So it's actually really interesting. I found that some of my patients like the voice, particularly if they're Star Trek fans, because they recognise it's the same voice because it's Major Barrett, and other patients don't really go for the voice, so I switch it off.
Yeah, it can get a bit loud.
Yeah, and you can obviously change the volume in there a little bit over there as well. Yeah, that's good. Well, why don't you come back and join us, and we'll have a good general discussion and take a few more questions at the end.
We have plenty of questions. One of the questions we've had quite frequently is lasers and how is it possible to use lasers in treating peri-implantitis? And if so, how could it be done?
So we can use lasers to agitate fluids. So the same concepts we were talking about in endodontics, we can apply around implants. And we have done some preliminary work on laser activated fluids for removing biofilm from complex implant surfaces and also for disinfecting those surfaces. There's one thing we need to be really careful about, and that is that when you go outside the territory of diode lasers and you run into the next family member rather, which is the neodymium YAG laser, the world gets quite different, because at higher pulse energies, that laser will actually melt the surface of an implant, which could be a problem.
Not so good.
But diode lasers themselves don't damage the implant surface, and we've done a number of studies on that. So they're actually pretty useful for basically thermally disinfecting the surface, but also for this activated fluid story. There have been quite a few studies done on enhanced implant integration, but the whole area of peri-implantitis treatment is, at the moment, a large void in the scientific literature. And so many groups are trying to look at ways of coming up with good solutions to that. And I suspect that a diode laser could be an integral part of one of those solutions. But I don't have the answer yet, but we are working on it, and many other groups around the world are as well.
So watch this space.
Absolutely.
Other questions about whether lasers have an application in situations of MRONJ or osteoradionecrotic cases or radiotherapy cases. Is there any evidence on that front?
There hasn't been a lot of research done on that yet. We know that the ability to enhance blood flow at those sites, because they have these fundamental necrotic processes that are happening, is probably a very, very good thing. But there's not been really well-controlled research, because these sorts of lesions, by definition, don't pop up in a way that you can do like a split mouth study on. And they're incredibly painful, debilitating conditions for patients in the first place. So there's not a large volume of research. It's very much at the moment simple, small case series and anecdotes, but it does need a whole lot more work. From a purely theoretical point of view, I think it has a lot of promise.
Next question, lasers and pulpotomies, presumably a deciduous tooth. Would you recommend a laser versus ferric sulfate?
Oh, that's a good question. A number of my pediatric dentistry colleagues have asked the same thing, and they've all bought lasers, which is interesting. One of the things you can do with ferric sulfate is obviously, treat a wound, in this case the pulp, and stop it bleeding. But that's all it does. It's basically a limited caustic burn. But what diode lasers can do is they can cause nerve sprouting, and they can boost hard tissue and soft tissue regeneration. So the biological outcome is different. You go beyond just having a simple burn to having something that actually heals in a different way. The same is true for pulp capping. 25 years ago, we did studies comparing pulp capping with calcium hydroxide versus using a laser, and we found that the outcomes were as good, but the biology was actually better. And many people find the ability to control the bleeding, and the speed and simplicity makes it a very, very nice choice. So quite a few pediatric dentists around the world do their pulpotomies now using a diode laser.
Well, Aidan, if I can bring you in, you've obviously been using this unit for some time.
Yeah.
If you're using it for troughing, how have you found your patients have experienced it in terms of post-op discomfort or concerns about the appearance?
Well, I just actually reviewed someone this afternoon. and I found it really difficult because we were working at the distal of a 7, for example, and the tissue was really bulky and hemorrhaging a lot. So I did some troughing. It allowed me to do a scan, which was really nice. And I spoke to him and asked, how did you go afterwards? What did you feel like? He said, well, I had some mild discomfort for a day or two. And he said it was, a 2 out of 10 or something like that. He said, in terms of healing, it feels great now. I'll brush it, everything's fine. I took the temporary crown off. The tissue was beautiful, absolutely beautiful. So, for patient experience, I think is great. And I also think, someone had asked me before, how do you explain using a laser when you're going to do a gingivectomy or something? Like, our patient's going to be worried about it. And for me, I found it so much easier introducing, touching up the gingival margins with a laser than saying, I'm going to get a scalpel out, for example, or something like that. And the kind of post-operative discomfort from, traditional methods versus using a laser is much different, I think. The healing is really nice and fast, and the discomfort they get is pretty minimal. I explained, like you were saying, about the discoloration for a few days, and it turns back to normal.
Okay. Now, a question back to endodontics. Do you have to get the final working length of the canal before using the tip of the laser?
Oh, that's good. That's a good question too. So there are a couple of different published methods on how to do the fluid activation and disinfection. Some of those, the tip actually stays in the middle third of the canal. In other ones, we've taken the tip to about 2 or 3 millimeters in the working length. It never has to go all the way to the working length to get the activation. You actually need fluid in front of the tip. And remember those pictures I showed, the bubbles? The bubbles are in front of the tip by about 2 or 3 millimeters. So you never have to get all the way down to the working length. So the answer is no. It's not. The length is not super critical because it's the fluid that's actually moving and doing the work, and the energy is dispersing through that fluid. Yep. There's actually specialized tips that we invented to disperse the energy even better, and those will do effectively everything from a 359 degree angle around the tip, and that was to make it almost operator independent. It didn't matter where you put the tip, it would actually activate the entire canal. And there are a few tips of that sort of design which have now started to come out on the market.
Aidan, have you had any experience in using diode lasers in either wound healing or in endodontics or perio?
No, I use it more for the troughing, the gingivectomies, recontouring, and stage 2 surgery for implants, for example. Yeah. I found that really, really helpful, as opposed to maybe using a tissue punch. Obviously it's not in a situation where you want to keep tissue, but if you've got plenty of tissue and instead of using a tissue punch, you can use a soft tissue laser as well. Yeah,
we found it really useful for doing surgery around implants. And also, if the tissue does get feisty later on, you can come around and contour that. Something you could never do with electrosurgery because you would just wreck everything. Yep.
All right. We've had lots of questions about frenectomies and tongue ties in adults, teenagers and children. What are your thoughts about lasers in those situations?
So laser or scissor are the two common most way that it's done, and either diode laser or erbium type lasers are the ones that would normally be used. The patient experience is different because the initiated tip of a diode laser is sensed as a hot object, whereas with an erbium laser you're cutting non-contact and the sensation is actually of a cool object. And I've had both these done on myself. In the mid-90s, we published a series of studies, which were ethics committee approved, I would add, which looked at the healing of intentionally created laser wounds in the mouth. And being on the receiving end of those, I can tell you from my own experience that they feel a bit different. So if I was having one done, I'd probably go for one that was an erbium laser rather than a diode because it just feels nicer as a patient experience. If you're doing without local, that is, of course. An older patient use local, so it doesn't matter.
Okay.
So, yeah.
Does each state have different licensing situations for a laser?
It does. In fact, we're currently writing up a document that will be for a future ADA News bulletin explain the difference. But basically, Queensland and Western Australia and Tasmania are the 3 regulated jurisdictions where there are specific requirements to have a possession license, a use license, etc. So they're highly regulated in terms of how you have to set up the room, the sort of signage you need and all those sorts of things. That's not the case in other states of Australia. So there is a fairly big difference there in terms of the complexity of setting up a laser, and even getting a laser in the first place in the 3 states that are regulated requires a whole bunch of paperwork and approvals and permissions. Very similar to as if you're buying an X-ray through the same sort of regulatory framework. Yep.
All right. And the final question, because we are out of time, I'm sorry. Using lasers to assist in tooth whitening, are we concerned about any particular damage to teeth or surrounding tissues?
That's a good question. So the damage to surrounding tissue normally comes because you've had a leak and your peroxide gel has escaped behind your gingival barrier for whatever reason. There have been quite a few studies which have looked at the health of teeth and pulps after bleaching, including with a laser and without a laser, and they all show there's no long-term deleterious effects on the pulp. So the answer is, from a lot of the studies, and there's been 2 recent systematic reviews, it doesn't seem to be a concern at all, which is good news to finish up on.
It's exciting technology. Well, we're out of time. Laurie, thanks again for joining us, for talking us through.
Been a pleasure, Peter. Thank you so much. And thank you to Aidan for coming along to join us as well. Yep.
And thank you for being with us. If you have any questions about the Ultradent Gemini 810 and 980 diode laser, contact your Henry Schein rep and they'll be happy to get you the information you need. If you're watching us on the Henry Schein website, click the link on the video page to obtain your CPD certificate. If you're watching us on Facebook Live, you can go to the web address on your screen to request your certificate. Thanks again, and see you soon on ScheinTV.